Everybody. Welcome to CSP Congress 2024. My name's Claire Small. I'm a consultant MSK physiotherapist in London. I'm also a newly elected CSP Council representative, taking up my seat from tomorrow at the AGM. I'd like to welcome everybody here to our first collective in-person event since 2019. Also like to welcome those people joining us virtually online, and we look forward to having some questions from them throughout the session. So today's session is a symposium. It's going to be chaired by Paul Shawcross, and the session's on building capacity of physiotherapists to support the working age population. And it aims to explore the existing workforce challenges, touching on physical and mental health data, implications of an ageing workforce, and the impact of the COVID pandemic. So as a CSP council, one of the things that we really want to do is be visible and accessible to members. So if you've got any things that you want to talk about with regards to the council and the work that we're doing with the CSP, please do come and find me during the breaks or throughout today, or find me online on social media. So Paul, who's chairing the session today, is from Coventry University, and he holds the role there of the Associate Professor in Physiotherapy. So he teaches across musculoskeletal, public health, leadership and practice-based models. He's the Associate Course Director for the MSc in Physiotherapy and Leadership pre-registration course at Coventry as well. And he's worked with a number of universities across the Northwest and the Midlands. So we'll be taking questions at the end of the session. Paul will lead the question and answer session, but there'll also be a Mentimeter panel throughout the session. So looking forward to a really interesting and engaging morning.
Thanks, Claire. Morning, everyone. Morning to those online as well. So just to lay out the session, I'm just going to do a brief introduction, and then we've got three excellent speakers this morning and some good variety, I think, on the panel. So we're going to start with Cameron, who is a physiotherapist by background, currently working in the NHS, supporting the NHS workforce, but also a researcher and completed his PhD in this area of practice as well. We'll then move on to Heather, who has got many years' experience as well, working in occupational health as a physiotherapist, but in various roles, I think. So clinical, mentoring, consulting, but more recently has had her own health problems that have impacted her ability to work as well. So she's got a really interesting view from the other side too. And then we've got Janet, who is a nurse by background, I think, involved in various things in occupational health, Janet, but I think an interesting role she has at the moment is as the deputy head of the School of Occupational Health as well. So three excellent speakers this morning, and interactive session. So just to introduce it, I think I had a look for a couple of key stats, and I think the most noticeable ones for me, which really show the impact I think that the pandemic has had, is that there's been a 55% increase in sickness absence in the last 4 years, so since the pandemic started. So huge increase. And I think this area is getting bigger. The government seems to be taking a little bit more notice of it as well. There's been various changes in legislation in the last few years. But equally, as well as that increase, there's a couple... an increase in days per employee of absence as well. So from 5.8 days to 7.8 days, which is a huge increase as well if you think of the percentage there. So it's not going in the right direction for those that are employed. Equally, and probably slightly more staggering, I think, is the amount of disability that we see in the UK. So the graph on the left there, you can see 20 years ago, there was just over 10 million people in the UK classed as disabled. That's now just over 15 million, so a huge increase there. It's an upward trend which is not going in the right direction. Wasn't going in the right direction before the pandemic, but it seems to have got even worse since then. And if we look at disabled people in work, the unemployment rates are much higher in this population as well. So this morning, as well as just talking about people that are in work and off work sick, also think of those that can't get into work because of their health, illnesses and disability. So that's my brief introduction. I'm going to hand over to Cameron now, who's going to tell you about his experiences.
Thanks, Paul. So as Paul said, I'm a physio by background, work at Buckinghamshire Healthcare Trust. Gone are the days of sports medicine and sports kind of therapy with people like elite tennis players. And it seems like we've come full circle, because I qualified 2009 and had to go overseas. There were literally no jobs then. And here we are in 2024. So I've recently finished a doctorate, and it was an applied nature of academia, so a mixture of health and business engineering. So today's talk really is going to be more applied at the micro and meso levels rather than the macro. And what we're talking about today really is supporting working age adults and minimizing suffering for these working age adults. And a good place to start is looking at the data versus arthritis data that we have. And I believe that we need to improve the support we have for these people. So in this data, we see that around 20 million people are living with a musculoskeletal condition, and 5.5 million people with high impact MSK pain. That's around 10 to 12% of the population. For those with MSK conditions, around 1 in 5 will see the GP, and this is costing a lot of money, 4.7 billion in terms of sickness absence for MSK conditions specifically. As Paul said, why are we interested now really in the media and the sound bites in the media? 7.8 days per person or people basically off work per year, and the vast majority of these people is due to stress and musculoskeletal conditions. If we consider the context as well, we're living longer, we're living later, and we will be required to live later into retirement ages. We also have healthcare shortages, the rise of AI and digital offerings. So that's the background. So as I've said in this slide, helping people stay in work is of equal importance as to trying to get them back into work. And as sickness absence is rising, disability is rising, I believe new circumstances require new approaches to address the issue. It seems like the current approach is not working, and maybe some of the pointers that we'll give today will be of benefit for you at an individual level. So if we look at a purely health and safety offering, shall we say, sometimes that can be counterproductive. So this slide demonstrates that generally in the workplace risks are decreasing. So the red line in this graph is increasing medicine. So medicine's increasing, therapeutic management is increasing, but this blue line, disability is exponentially increasing. So something's missing from our thinking. What is that? What are the solutions? We hope to offer some of those today. And what we must see really, especially in the musculoskeletal side, is that common health problems are common. That might sound trite, but that's the case. 80% of cases don't neatly fit into this health or safety box. And this data is from Scandinavia. So patients that didn't attend with their GP or healthcare professional in the last 30-day period. I think this data is from Sweden. The prevalence of common health problems is very common, as I said. So 60% of people tired, 75% of people with at least one symptom, and more than 50% reported at least 2 symptoms. So what we need really is smart physiotherapy, and within that we need smart physiotherapists to prevent this slide to disaster. So as we see, before a health problem, you're a person. At the onset of a health problem, you're still a person. At the time of seeking healthcare, you're a patient. And if you're signed off work, you're a beneficiary. And if you don't recover, you're dispossessed. So this can lead to large obstacles to recovery. And these labels carry excess baggage. So we feel differently. People treat us differently when we have these labels. And these labels can remain with people in the future. It's not an uncommon situation. And as we see this slide, we know that the longer people that are off work, the harder it is for them to recover and get back into work, but also the increase in disability. So to reinforce this point, sorry to Kent and Medway wheelchair service, but I'm happy to take this down if this isn't accurate. But this just reinforces the point that employees as patients face barriers. Some of those can be seen, some of them may not be seen. What about us in healthcare? So on this slide as well, I've documented here that in this study, many people struggle with the physical components. Around 4 in 10 people had problems in work. So it's incumbent on us as physiotherapists to address these problems, shall we say, and it's supported through multi-stakeholder approaches, research, government practice, guidelines, clinical guidelines. And the question to you as individual physiotherapists or those interested in healthcare is, are we doing it?
What it is, because your core's weak and your spine's in the wrong place and your hips are all wrong and you can't walk or stand properly, that's why you're getting these problems. If you've got a tennis ball at home, if you've got a golf ball at home, if you've got a cricket ball at home, okay, well, buy all of those. What do you do for a job? Office, no good. Sat down all day. That's your problem. You sat down all day. Your spine, your hips, everything's in the wrong place. Can you do anything else? Builder, no good. On your feet all day, no good. Those are shoes you wear. Get rid of them. They're doing you no favors. Get rid of them. Your neck's in the wrong place. Just looking at you now, your neck's in the wrong place. The main thing is, though, with injuries, is to stay positive.
So what do we say to people? That person is a comedian. You'll be thankful to know he's not a physio, but he's picked that up from somewhere. So it's one thing having work conversations, but what we need to be interested in is the content. And that comedian has highlighted the content that he's heard from somewhere. So it's what healthcare professionals say during a conversation, not simply just talking about work. That is very important. Are we giving positive messages? I've put mountains in this slide because that's the analogy. The analogy is that people face obstacles. And as physios, we're very good at overcoming obstacles. We see them as obstacles that can be navigated around instead of going right over the top of these mountains. So we want to avoid falling into the trap that immovable objects cannot be navigated around, okay? And having work conversations for many of us today might be new. And I would argue that we need further training in this area. I'd like to hope, though, that all physios can provide kind of vocational advice and coaching, education skills, and this ability to build practice. So we need empathetic listening, not sympathy for people, gentle nudging that's not dictatorial or judgmental. And the focus really is in empowerment and a co-production. So are you co-producing plans that are of benefit for your patients? So smart solutions are required. It'd be beneficial to weave advice and positive messaging that we can into things like the fit note, in reports that you might write to other healthcare professionals or for the individuals themselves. And what we know is that it works. The challenge is that healthcare can hinder or it can help. We would like this empathetic approach to helping, obviously. So I put in this slide some positive messaging that tends to work in practice in occupational health, and what we want overall for all of us in physios, primary care, secondary care, hospital settings, non-hospital settings, private and public, that this focus of work-focused healthcare. So this is about best practice. We understand as well that the context is important, so there are healthcare concepts as well. The bigger picture is there's probably a public health campaign that's required. It'd be good if CSP would support that with us, and ACPO being kind of leaders in this area, improving work conversations for physiotherapists in general, and also bringing it all together. So considering the learning and development needs of physios in this area. So this is the best practice, we believe. And the focus as well is in supportive employers, because we understand that we can't take this out of context. We need employers to be supportive. We need them to enable their individual employees as well, day one or even before. So these are the key enablers. So it's not a purely health and safety approach, albeit that in itself, these approaches have value. We need a complex grasp of human nature. And if anyone hasn't read Dr. Adrian Massey's book, Please Do So, Sick Note Britain. It's a illuminating read, shall I say. So he argues that the approach that's needed is a human approach, which involves our patients. So overall, common health problems, as I said, a human approach is needed. Healthcare has a role, but if we treat people only, we take them out of the workplace, we can isolate them, and removing them can also act as a barrier or an obstacle to their recovery. We believe that temporary modification of work is important, and it works, it's effective, it's cost effective, it reduces work days lost. And overall, we need this work-focused healthcare. And over to Heather. Thank you. So my challenge to you is, I believe you can do it. We hopefully can show you the direction and help you in considering work-focused healthcare for your individual patients. So thank you.
Hello, good morning everyone. Well done for being here early. So I'm Heather. I'm going to be speaking about supporting patients to return to work after stroke, cancer or serious trauma. And as Paul alluded to, my background is in occupational health, mainly in musculoskeletal work. I've also then spent 10 years working with major trauma clients. And then I found myself on the receiving end of stroke care and cancer care, and as a patient, and how illuminating that was. So that's really what's fired me up for today. So it is going to be a whistle-stop tour of these areas. I'm just interested to know if there's anyone in the room who does work with stroke patients. Give us a wave. Yeah, a couple. Great. How about trauma, major trauma in hospital, maybe acute? Yeah, brilliant. And what about cancer services? Got a few of those. Fantastic. Okay. So it is going to be a whistle-stop tour of those three areas. We will touch on what vocational rehabilitation means within that. And those of you who are kind of purists of occupational health will see they are very similar. And briefly, the opportunities to extend your skills into these areas. I may slip into some of these acronyms. VR is vocational rehab. RTW, I'll probably say return to work. OH, occupational health. And HCPs as healthcare professionals. Okay. So over 100,000 people suffer a stroke in the UK every year, and most of them, a third of them, are under 65, which means they probably need to be thinking about returning to work. So sorry, just get my notes in the right order. And so many people who survive a stroke are thinking they're going to need to return to work, look at returning to work, but it may look very different from how they originally envisaged it. In 2022, I was invited to represent ACPO and the CSP on the NHS Task and Finish group for creating some vocational rehabilitation guidelines to be embedded within the NHS pathway. It was a really fascinating experience with lots of other stakeholders. It was brilliant. And the outcome was a toolkit, which is a very comprehensive toolkit for clinicians. It can be found on the e-learning for health website, and it's also in full on our ACPO website, along with a nice little animation summary as well. So if you don't want to sit through and look through the whole toolkit straight away. The right button to move on. I want to give you a summary though of it, and you can see in the triangle here, this is the framework that the overall guidelines came up with. It's a 3-level framework, with level 1 being the most specialist level intervention. Now, this is aimed at people who do not necessarily have a job to go back to anymore, and it's expected that they're going to take more than 6 months to return to work. Level 2, which will look more like occupational health to many of you, is aimed at those who have a job to return to, and that they're expected to be able to return to that job within 6 months of their diagnosis. And that's obviously looking at their current work function in relation to the job that they have, liaising with the employer, return to work planning, supporting reasonable adjustments and those sorts of things. Level 3 is across the board advice and signposting for every patient who has a stroke who may need help going back to work. And this is where the entire physiotherapy workforce has a role to play in terms of being able to have these work-related conversations, knowing where to signpost people for support. And several of the stroke charities do have quite significant information about return to work. Now, some current research that's ongoing The University of Nottingham are very prolific in their research about return to work rehabilitation. I have to say the OTs are the ones doing it. We need to get ourselves in there and join them as physios. But there's an ongoing research study called the RETAKE trial, and it's about early stroke-specific vocational rehab and about placing that vocational rehab intervention within the clinical pathway from the beginning to the end. And you can see it's about early assessment within 8 weeks of diagnosis of a stroke. It may still be in inpatient and acute settings, or it may be in the community setting. The person is assessed, they're given an individually tailored package of support, which looks at their coordinating their return to work, educating themselves, their employers, and monitoring that return to work until they're able to either go back into work or explore alternatives. The final results are pending, and I should mention I can put together a document with all the references in here for those that want them afterwards, because this is a fascinating trial that's ongoing. Okay, straight on to trauma. So every 20 minutes in the UK, somebody is admitted to a major trauma centre with life-changing injuries. The data on the right is from the charity Day One Trauma Support that I'm very privileged to be a trustee with, and this is based on their 1/4 of their data this year. You'll see the overwhelming majority of patients with major trauma do have orthopaedic polytrauma, closely followed by brain injury. Therefore, many of these patients will need to be returning to work. They'll be expected to return to work. The average age of major trauma patients is under 40. So this group are surviving their trauma much better, because we've now got major trauma centres and networks that mean survival is much greater. Therefore, people are going to be living longer with their life-changing injuries, and they need to be able to return to work. So in 2022, NICE produced some lovely, really lovely, excellent clinical guidelines around rehabilitation after trauma. However, the word work was mentioned just once in the area on self-management. And really, when you look at the type of injuries these people are suffering, which might be multiple fractures, amputations, just going off and finding a little bit of self-help resource about return to work is not sufficient, in my opinion. So let's head over to Nottingham University again. This is the ROTATE trial. I'm actually sharing with you today a little bit of the preliminary findings. They did a preliminary qualitative study about factors that were preventing the implementation of a vocational rehab pathway within the major trauma clinical pathways. And I'm sure most of these won't come as a surprise to you, but NHS policies was a boundary, funding was a boundary, and communication between the acute hospital-based care and community care, which we'll come back to. A local NHS service structure is not set up for vocational services, whether patients were individually ready, but actually a massive failure to recognise that vocational rehabilitation and return to work was a priority. And they identified that there was a mismatch between the system and the need, that the system does not recognise the multiple injuries and conditions that these people are living with, and that there was a deep-seated belief in healthcare that vocational rehabilitation didn't belong in the clinical pathway and it wasn't a priority. So those were their findings, yet there is extensive evidence that that vocational rehabilitation as an early intervention can change outcomes for the long run. So the trial that's now proceeding, the study protocol has just been published this year, is going to involve 5 major trauma centres. 5 major trauma centres, and actually following patients, a little similar to the stroke trial, very early on throughout their clinical pathway, supporting them. There's one other piece of research that I wanted to share with you here. This is about early vocational rehabilitation in some of the other major trauma types of injury, a systematic review. Published in 2021, it looked at acquired brain injury, severe psychological distress, and spinal cord injury, which are significant but less in volume. They found some fascinating facilitators for return to work in those conditions, but overall their findings were that better vocational outcomes, more people returned to work when these 3 factors were taken into account. Early intervention within the hospital setting before discharge. sustained monitoring and follow-up of that return to work support until somebody was in and sustaining their return to work. And the integration of vocational rehabilitation should be treated like other therapies within the pathway, that there should be physical, mental and vocational practitioners within the multidisciplinary team. And you will see that as a theme as we go into cancer. So every 2 minutes, somebody is diagnosed with cancer in the UK. It's kind of huge and a little frightening. And it's also very frightening that 1 in 2 people will now get diagnosed with cancer at some point in their lifetime. So the good news, though, is that we've got effective treatment. Many people are being treated effectively, recovering from cancer and or living with cancer. But they need to do that in the context of work and remaining in work for hopefully for a long life. So another charity, Working with Cancer Charity, they carried out a study along with the Institute of Employment Studies and published their survey results in February 22. Whole host of findings, highly recommend giving it a read. It's not too long and it's not too jargony. But the top 2 findings were that many patients felt guilty about taking time off work. I'm sure many of us can relate to that. They worried about being a burden to their colleagues. They were unaware of their rights under the Equality Act. But maybe more surprisingly is over 50% of them had no access to any support. Nothing from their medical team and nothing from occupational health or HR. Now, that may be because lots of people are not in work with employers that have those kinds of services, but nobody spoke to them about work, despite the significance of this health problem for them. So the survey called for healthcare professionals as a general rule to consider return to work as a healthcare outcome and have that conversation early, to improve training for healthcare professionals around how to have those return to work conversations early on, and to help employers understand the implications of the Equality Act and what reasonable adjustments might look like. There's actually not a huge amount of academic research out there about return to work in cancer, but there are some interesting reports. So the European Agency for Safety and Health at Work released this one in 2018. Nice, huge number of countries involved, so we've got quite a good picture of what's going on. They found there were 5 main symptoms for cancer patients that were making it difficult to work. Those were fatigue, emotional strain, diminished physical and mental health capacity, pain, and cognitive capacity in terms of attention and memory. But they found that 3 main things really helped and supported return to work. And they were what they call psychoeducational interventions. I have to slow that one down a bit, about return to work. So that is information and signposting, training, for example, helping train people on how to design a return to work plan, workplace accommodations and reasonable adjustments, such as flexibility around hours and time off for appointments. And here we have the multidisciplinary team again. They found that if there was a physical, mental health and vocational practitioner within the team, then return to work rates improved. They also identified some good practice from Macmillan in the UK, and that's the next slide I want to share with you. So although it's not academic research, this is a really interesting framework. So this was published in 2012, and it came with 8 outcomes on how to support cancer patients better with return to work. The first, we're just going to look at the first two. The first one is the strategic framework, and a strategic framework needed to be developed, and that basically the document goes on to present that. But this support, they said, needs to be embedded within the clinical patient pathway. There needs to be liaison between the patient, the healthcare professional, and the employer, and that it cannot be relegated to an afterthought, which is sadly where it sits most of the time now. The second outcome was a 3-level model. If you think back to the stroke model at the beginning, it's similar but different. It's turned on its head for a start. So what we've got here is that level 1 is the lightest touch intervention. And this is about providing information and signposting and support to anybody who presents with cancer. Level 2 is a significantly lighter touch than the stroke version level 2, but the people who have specific concerns or worries about work should be pointed to more specific self-management support. And then level 3, which is more like the level 2 and 3 of the level 2 and 1 of the stroke guidelines, is that the people with very specific and complex needs around return to work should be referred to a specialist vocational rehabilitation service. So we can see that there's some themes emerging across these 3 different types of condition. And so in summary, there's really 4 things that I've drawn from looking at this combination of conditions. The early intervention, having work conversations while somebody is still in hospital before discharge, can really make a difference, even though it might feel a bit too soon for clinicians. So being able to have that conversation is important. That there is a need for different levels of service depending on the different needs and the different stages that the patient is at on their journey. It's assumed that people are going to need return to work, maybe 6 or 12 months after they've been ill, but they might need it earlier. They might need it much later. You don't know until you work with them. The third theme is the crossing of boundaries. There needs to be improved working between sectors, the NHS, the charity providers, private therapy and medicine, and the employers, crucially the employers of the workplace. And that fourthly, vocational rehabilitation, return to work, should not be relegated to an afterthought in terms of planning and providing for therapy provision. So in terms of opportunities, training and support, in theory there's loads, but in practice there's not that many roles out there that specifically include this. There is a massive gap in NHS vocational rehab service provision. All these guidelines and research is wonderful, but there's very few of these services in existence. Provision at the moment is mainly if you have a legal claim, you might be able to get support. If you've got an insurance policy, you might be able to get support. And if you work for an employer who has a good occupational health department, you might be able to get support. The reality is many people can't. So there's an opportunity for us to support our patients as physiotherapists within clinical settings by increasing our own knowledge of return to work, vocational rehabilitation, occupational health, all those sorts of things, taking up extra training, looking at those specialist posts when they come up. And ACPO, the Vocational Rehabilitation Association and the Society of Occupational Medicine all have varying support structures and courses in place. But really I want to echo what Cameron was saying, in that whatever our role is, whatever service we're in, and whether we consider ourselves to be occupational health professionals or not, the very minimum we can do, which is still going to be effective, is have positive conversations about work as early as possible with a client and a patient who wants to have that discussion. And please don't underestimate the need of somebody in hospital worrying about their work very early in their illness. So if we can do that, we can signpost and support those who need it, we can make a fundamental difference in somebody's return to work outcome, which can have a fundamental impact on their future quality of life. Thank you very much. I'm going to pass over to Janet. Oh, no, we got
Brilliant. Thanks to Heather and Cameron. So a real range there of different conditions that will affect different people. We're now going to move on to a little bit more of an interactive session before Janet talks. So we've got a Mentimeter, if you're familiar with that, and we've got a couple of questions for you to consider. So there's a QR code you can scan on screen there, or you can go to menti.com and put in the code that's on screen. 2 questions we're going to have a look at, and 2 questions we'll have a look at your answers as well. So the first one is to think about what's been your biggest challenge in supporting the working age population. I've already put one answer in. My suggestion was the lack of time. So you can agree with that, but put some other responses in there as well. I'll just give you a few minutes for that. Whilst you're doing this, I'd like you to think about across maybe different roles that you've had as well. So even if you don't see lots of working age population at the moment, maybe previous roles. And I'll talk through some of the answers as they come up. So time is coming up already. It looks to be one of the first ones, which I expected. I can see resources and education. Bit of a theme there as well, training. Facilities coming up there. So I think, yeah, interesting one. I think the facilities to be able to do what you might want to do with that population as well. The expertise, so I guess linked with the education side of things and the training, competency. Lack of respect is an interesting one. Appointment attendance. Yeah, absolutely. The skills. And I'm seeing some similarities. I've just been involved in some research looking at the fit note. So I think Cameron briefly mentioned this, but the fit notes, which physios have been able to complete for over a couple of years now. We've just done a bit of research and got just over 400 participants, and we were looking at the facilitators, the barriers to people completing the fit note. And you've pretty much summarized what we found in our research here, to be fair. So a lot of people felt it was the competency, the awareness, the time, the resource, the training, the access to that. So some really similar things. So really interesting. And I think we need to acknowledge that there are these barriers and challenges that we need to overcome. It's not easy. The task that I guess we're trying to set you today is a take-home message to talk to more people about work and think about different ways of doing that. There are barriers, there are challenges to that. Equally, I think the fact that everything seems to be going in that trend of getting worse, we have to try and find a way. There's no doubt we have to. You know, I think the stat I put up earlier about disability, that's a quarter of the UK population have got a disability. It's huge. So really interesting. Thanks, guys, for filling in that. If we can go to the second question now, please. So think now to overcome some of those challenges and barriers, what do you think the number one support you need is? What do you feel, if there's one thing, what do you feel you would need to be more confident, more competent in discussing work with your clients? So it should come up, that question, for you, hopefully. Yeah, brilliant. So I was hoping that education, training, resources might come up top on this, because that's probably the biggest signpost that we're going to make you today, as to where that is available now in terms of extra training and resources and where you can access. I think still the problem comes to time to access and spend time getting competent in accesses and using those resources. But yeah, you know, that's certainly going to lead us on to the next session, where we're looking at maybe some of the things that the government are doing to support on this as well, and where funding is going. So that's brilliant. So thanks very much for your engagement with that, guys. Lots of responses. Time, training, education seems to be top. Resources, there's some other things there which I can appreciate as well, like manager support, organizational support, the space, the trust, maybe, some really interesting things. So I think that's quite a nice point then to move on then to Janet then, who's going to talk to us about maybe some things you can do. So we'll move on from that, please, back to the slides.
Hi, everybody. It's a bit awe-inspiring standing in front of this physiotherapy audience when I'm not a physiotherapist. And thank you to Paul for introducing me as a nurse, an occupational health nurse, earlier. My role is Deputy Head of the National School of Occupational Health, and my particular focus is on nurses and allied health professionals. But I also work for a private occupational health provider, and I can say I've been extremely privileged to work with physiotherapists within occupational health over the last 15 or 16 years. And that's grown from 1 or 2 physiotherapists to, I think we've got over 50 physiotherapists within PAN Group at the moment, and continually growing. If anybody looks, there's loads of adverts out there. I wanted to pick up on something that Heather said earlier, and I'm just going to pop onto the next slide, is that actually there are only 45% of organizations that have access to occupational health, maybe 50% at a push. But if you can see that half of that working population do not have access to occupational health. And I'm sure you can see from Cameron's talk and what Heather's been saying, that work as a health outcome is essential. It's really important if we are going to change those statistics that you saw at the beginning from Paul and Cameron. They really are huge. And some people are calling us a sick nation, really, because of the number of people that are out of work. And we can stop that. We can make a difference. And the government has also noticed that there is a difference. So way back in 2008, Dame Carol Black brought out Work as a Healthier Nation. Actually, I haven't got my glasses on and I can't remember it. So, but that was the first time that occupational health there was a focus on occupational health for supporting those people that are out of work, to help them to get back into work, but also to prevent people going off work. And we know that musculoskeletal issues are a huge part of that reason. And then we move on to Health is Everybody's Business around 2019, a greater focus on occupational health, a greater focus on actually everybody needs to be thinking about workplace health. From that, there was the response to Health is Everybody's Business a couple of years later. And this is where we in the National School came in, because we started a task and finish group with the Department of Work and Pensions and Joint Work and Health unit, looking at how do we improve that access to occupational health. Now, one of the big issues that we have is the occupational health workforce in itself. We are aging. The working population is aging. We are depleting as we get older. We're mirroring that workforce, and so therefore we need to grow our own workforce. We can't improve those figures of access unless we grow that occupational health workforce. So I suppose one of my little asides is yes, please have work as a health outcome, but actually we need to be, there may be some people that want to have think about moving into occupational health as well, because we are all really passionate and we feel it makes a difference. And I'm going to move on to that a little bit more later. Then there was a consultation last year called Occupational Health Working Better, where everybody was asked about their opinion on how to improve occupational health. And the multidisciplinary team came out quite significantly from that. We need a multidisciplinary team. We need the skills that everybody else is bringing. Yes, we need to be upskilled and educated, as everybody has indicated, but we need those musculoskeletal skills to address the musculoskeletal issues. And we can't just say, oh, it's just musculoskeletal, because I'm sure you all know the impact that having a chronic musculoskeletal condition or a traumatic condition or stroke or cancer has on on mental health, and vice versa. So they go hand in hand. So we cannot do without a musculoskeletal workforce within occupational health. And that was the point of our task and finish group, was to start looking at how do we grow our workforce. The government put in a phenomenal amount of money into different initiatives, a lot of them digital initiatives, and a huge focus on musculoskeletal health from there. And they started the Occupational Health Task Force headed up by Dame Carol Black, which is ongoing at this moment. They put money into WorkWell services. So that's a new initiative which only sort of launched last week. And that's mainly looking at how do we support those people that are already out of work back into the workplace. So the previous government put a huge focus on occupational health, and I think absolutely rightly so. But as Cameron said, it hasn't worked fully, and that's where we need to put our focus. And one of the reasons I believe is because we don't have the workforce in order to be able to meet the demands out there. We need to grow that workforce, and that includes the education and the training that you've been talking about. But that WorkWell service, 50% of it is focused on musculoskeletal, because that's what the problems have identified. This current government haven't mentioned occupational health at all. However, I believe the Darcy report is a fantastic business case for occupational health, because if we look at just the NHS workforce itself, the NHS workforce need care, they need support, they need that well-being and cultural change that occupational health is so well versed in supporting. And something that absolutely shocked me as being an occupational health practitioner who's worked with physiotherapists for the last 15, 16 years is to find out that there's a number of trusts out there that don't even have physiotherapists as part of their occupational health team. And I think that is really sad. But I believe that's going to change, and that there's a huge focus on that, and that's going to come with this government and the Darcy report. But the other thing that occupational health does is really helps the NHS by reducing the need for the NHS. If we think of that working population, it starts at around age 16. And I was assessing 90-year-olds during COVID. So it's a huge range of age groups. It's a huge part of that population. And everybody who's in work has an impact on their family and their society and their community. So that all grows, if you like. So if we can help people remain in work, if we can help people proactively be healthy, and especially since we know musculoskeletal is a big part of that ill health coming out of work, we can help that NHS. If I go back to Waddell and Burton in 2006, they said that being out of work was equivalent to smoking 10 cigarettes. So that's the impact. There's a 20% higher mortality. There's a 20% higher consultation rate, medication rate use. So if we do a good job in occupational health, if we have the workforce to cover, then actually we'll make a big difference. And also I think the announcement yesterday around the employment law will make a difference, because employers need us. We have a good impact on employers. And support employers. And with the change in the law that's going to come around the employment law, hopefully there'll be a bigger uptake in occupational health to support the workforce from an employer's perspective. And certainly, as you can see, there has been a lot of government action, and we really just want that to continue. But what are the opportunities that so it's all very well to say this is what the government's doing, but actually what are we doing in our workforce, in our sector? So the Council of Work and Health, they've brought together all of those organizations. Heather talked about Vocational Rehabilitation Association, ACPO, and they actually produced a report in 2016 focusing on the importance of the multidisciplinary team. And actually, that's where my job came from. So I have to say thank you very much to them for that. But of course, the national school that I'm with, our focus being on the multidisciplinary team. The Society of Occupational Medicine, they went from doctor only to doctor and nurses, and now they're embracing the allied health professionals. We have special interest groups that are focusing on allied health professionals, which include physiotherapists, OTs, nurses, doctors, etc. And we're actually looking at mapping how the whole workforce fits. And that's a project that we're doing at the moment, which Cameron's involved in as well. But significantly is ACPO. ACPO's been going for the last 20 years. They have an amazing number of courses that people can use to upskill themselves. They're extremely good. Even as a non-physio, they are very good and very helpful. So strongly recommend that anybody who hasn't had a look at ACPO does go and have a look at ACPO. Competencies they're building or built actually. And as you heard from Paul, they're very evidence-based, lots of ongoing research. There was a change of heart, and this is where I think we've come from and we're going to. Whereas before, maybe physiotherapy was somebody's brainchild, or let's bring in a physiotherapist, to actually this is very mainstream. And the Faculty of Occupational Medicine have now opened up their diploma in occupational medicine to allied health professionals. And that's only happened this year. So that's a really big landmark change. And that gives people a really, that holistic education around work on health and health on work, that proactive as well as that reactive. And that's where physiotherapy fits beautifully in occupational health, because of the proactive work as well as the reactive work, the treatment and the rehabilitation. Now, the Society and National School, we've pulled together the mentoring scheme, of which Heather mentioned earlier, and that's where anybody who's thinking about occupational health as a career move can come in, get a mentor. There's loads of resources there, and they can get support in decision making, get to understand it. And I suppose even if your decision is not to move fully into occupational health, but to use elements of that, it's a great learning tool. But I just want to say that actually there's a number of universities that are incorporating allied health professionals and physios. The Nottingham University MSc in Workplace Health and Wellbeing, I did that course. It was amazing, and it's multidisciplinary. And something that on the back of this we're finding is that ability to have interdisciplinary learning between all of the workforce within occupational health. So that's been a really good knock-on effect, if you like. Robert Gordon University has a great course on occupational health, which includes physiotherapists, OTs, nurses, and etc. The same with University of Cumbria. They also have an excellent course on occupational health. But if anybody just wants to go to the basics and get a little free course that's really just opens your mind, ELFH, the NHS ELFH, they have a free course on there on work and health, which includes mental health, musculoskeletal health, older workforce, younger workforce. And it's just a great opening, if you like. So always strongly recommend that one. And then my last slide, so you'll be pleased to hear that I'm coming to an end. We really want universal access. We want 100% of the population to have access to workplace health, to workforce health, to occupational health. Absolutely, we want to get there. And to do that, we need to grow our workforce. But I also want to focus on why we're such a meaningful specialty, if you like. And this comes from the Society of Occupational Medicine, and they've got some amazing resources there. In fact, Cameron is actually speaking a webinar in a couple of weeks' time on the 28th of October, if you want to have a look on physiotherapy in occupational health, so if you want to have a more in-depth understanding. But you can see here, I'll leave you to read that, there's a huge impact on the employees, the workforce, the employers, which means creation of jobs, better jobs out there for people, and of course the economy. And really dear to my heart is society as a whole. So public health and social health and well-being, reducing health inequalities, which is what happens when people fall out of work. And that's me in a nutshell. I could see Paul hovering there.
Brill. Thanks, Heather. So I think we've just got about 5 minutes time for 2 or 3 questions. to the panel. So keen for kind of some reflective discussion, really. I think well, we'll go through the kind of take-homes as a final bit from me, but thinking about your own capacity, you know, and supporting the current, but also the future workforce. So we've got a roaming mic, which is going to be thrown around, I think. And if there's any questions online as well, please do type into the chat. But have we got any questions? First one to start, really.
So thank you very much for that presentation and the slides. I think that was very informative. I think you're absolutely right. So personally speaking, even though I'm not in the field of occupational health per se, but I work in a private practice, and I think gaining knowledge and competence in occupational health is inevitable now that we're talking about person-centered approach of physiotherapy and trying to think more of enabling people and asking about what matters to them. Work is key then to start paying attention to. The resources were great. I just wonder if in supporting current and future workforce, there would be any kind of campaign or lobbying for more universities to do some endeavors, just like Nottingham University you mentioned, to kind of integrate these modules into the programs more, or if that's already the case, and whether it would be okay for people, physiotherapists and other allied health professionals to kind of undertake individual modules as opposed to doing the whole master, to just make it probably more accessible. Thank you very much.
Bill, so I've got a couple of comments on that, but just open it up to the panel first. If anyone's got any.
Just that all of the universities I mentioned do standalone modules, so you can do them individually. And something I didn't mention is that we're strongly, part of my role is to strongly encourage people to come and shadow occupational health departments so that they can get a feel for what is done.
Thanks. And yeah, I'm aware of some work that's going on. So with the Health Education England framework of now looking at advanced practice, and there's some work done at this enhanced practice, which some of you may have heard of, and I think there's a talk tomorrow about that, which is a new kind of layer which is coming in kind of band 6 type level. And I know there is some work being done to look at where does workplace health fit into that as a key topic. And I know at the university I work at, there is some work looking at standalone modules that people could pick. So I think there's work being done. We'll see what comes.
You're coming over to me over here. So we've got Nidhi online is a 3rd-year apprentice. Do you feel more funding could be allocated to ensure high quality of life for working age population, in addition to the funding that goes into elderly care?
Sorry, the last bit, sorry.
Shane, we talk a lot about elderly care, but we don't talk about kind of funding into working age population. So people can spend more time in well health.
Cool. So yeah, I think that there is a need for more funding would be my thoughts. And I suppose that's the thing that the previous government were looking at. And the question is now, are the new government going to look at that as well? But any comments from the panel on that one?
Just yes.
I think as well, the expectation is we'll be living longer. Traditional retirement ages are going to change. So you might get people who are working throughout the call it the workforce. So they may be the ones that are picking up the gig economy when they're 65, 67, 70 to supplement pensions when there's not so many younger workers to fund those pensions. So they're the people that we might want to focus on. So that's where the resources may need to go.
Thanks, Cameron. Have we got time for one more? Or yeah. So,
Obviously, with these other types of health conditions, these guidelines are fabulous, but the services don't exist. So if we could have funding into those services, because we know they make a difference, that would be amazing.
Hi, Lisa, therapist based in London. I wondered if you kind of had any views about the move in MSK care for things like community appointment days. So where the MDT team is embedded in one place, whether you had any views on that.
okay.
If you don't know what they are, basically, There's a one-off appointment. It's what matters to you discussion. You could see a physio, you could see someone from social care, you could see someone from the Department of Work and Pensions and Employment Centre, and they're being trialled across the UK at the moment.
And I think it's an amazing proposal. I've seen something about it, and it makes complete sense with so many of these guidelines saying let's bring the multidisciplinary team into one location. And my own experience around clinical management, there was not a vocational person in sight, but I was at the hospital 3 times in 1 week to see 3 different specialities and never saw therapists. And so if we can have one location people can go to and speak to the variety of people they need to, including non-traditional members of the team, social care, finances, benefits, things like that. That's going to be really invaluable, and we need to see more of it, in my opinion.
Thank you. I think we're at time. I'm getting lots of people looking at me over there. So I suppose just final close before we thank the speakers is just hopefully we've shared opportunities for people already working in occupational health, perhaps in MSK practice, to think about other people they could support and use that expertise, and those of you not working in occupational health but supporting that working population. Hopefully there's some good ideas and resources there for you to go and access. So thanks very much to our panel for today.
And I'd just like to add my thanks to Paul and his team for a really interesting collaborative session that's given us some good ideas of things that we can take back into our workplaces next week. So thank you all. Our next speaker is Lisa Newington. Lisa is based at Queen Mary's, the University of London, and also at Barts Hospital at the Centre for Bone and Joint Health. Lisa's going to be doing 2 presentations today. So I think what we'll do is that we'll ask her to present both papers and then open the floor for questions at the end of them. So the first paper is on the effectiveness and characteristics of work participation interventions for adults with musculoskeletal upper limb conditions, a systematic review. And the second is on supporting work participation for adults with hand and upper limb conditions, a survey of the British Association of Hand Therapists. So obviously both papers really interesting to follow on from this morning's first discussion. So welcome, Lisa.
So these are not about community appointment days. I wasn't seeding something there. So thanks for the opportunity to present our systematic review. So I need to acknowledge that this was funded by the CSP Charitable Trust. So that's a good thing. Keep that going through a postdoc research grant. And this is the wonderful team who are involved, a mix of hand therapy and occupational health professionals. And we have no conflicts of interest. So the aims of this review were to identify interventions that improve work participation for adults with upper limb MSK conditions, and to explore the contextual factors and mechanisms. So we were interested in, from these interventions, what worked well and for whom in what setting. We included adults with traumatic or non-traumatic upper limb conditions, and we were looking for studies with work participation outcomes. And work participation was defined as a person-centered thing. So as we discussed earlier, it was about return to work, but also remaining in work, increasing duties, increasing hours, and work productivity. We included all study designs with the exception of case studies. And so we registered the review with Prospero. We had fixed eligibility criteria. We screened the papers. We measured quality assessment and risk of bias. And then we summarized everything together as a narrative synthesis because the papers were too disparate for meta-analysis. So this is the Prisma flowchart, just shows the process of the review. The main things are, we initially found more than 3,000 papers, and we whittled this down to 22 that measured the outcomes and the interventions that we were looking at, and these were reported in 23 studies. So across these papers, we found 3 different work participation interventions. There were those that focused on ergonomic interventions, those that focused on exercise, strengthening and conditioning, and those that had a multimodal or multidisciplinary approach with elements of psychology and exercise and ergonomics and a few other factors thrown in. There were 4 outcome domains that were measured across these studies. The first looked at return to work, the second at self-reported work function, the third at work productivity, and the fourth at work-related costs. So this infographics shows the results of the systematic review. I'll talk you through it. The columns represent the 3 different interventions. So you can see ergonomic, exercise, and multidisciplinary. There isn't a laser, so you'll have to look yourself with your eyes. The rows show the work-related outcomes. And then that was also split into whether the intervention was delivered in healthcare or in a workplace setting. And the colours represent the risk of bias. So the green studies are the low risk of bias, the orange are the medium, and the red are the high risk of bias studies. The size denotes the sample size. So the larger, the bigger sample, the smaller sample. And the shape is the type of study. So randomized control trials are the circles, and all other study designs are the squares. And so if you look down, you can see, if you look at ergonomic first, we rated the studies if they reported a statistically significant positive impact of the intervention, that was rated in the positive column. If there was no difference, we rated that in the medium column, the neutral column, sorry. And if there was a statistically significant detriment of the intervention, that was in the negative column. So if we look first for ergonomic, you can see there was a mix between positive and negative, positive and neutral, with the majority actually sitting in neutral. For exercise, where all of the studies were randomized controlled trials, the majority are sitting in the positive impact. And then for the multidisciplinary or multimodal studies, most of them are in that neutral category, with only the uncontrolled and poor quality studies reporting a positive outcome. Interestingly, 2 had negative outcomes, and these were associated with the increased cost of delivering the work participation intervention and increased sick leave, which was associated with leaving work to attend the work participation intervention. That's interesting. So in conclusion, the evidence-based interventions appeared to have a positive effect. The picture for the other interventions was really mixed, and we couldn't draw any firm conclusions. But overall, there are really few high-quality studies. And if you remember back, the second aim of mine was to look at the contextual factors, and these were so poorly reported, we didn't know much about the occupation or the demographics or even many of the clinical details for the patients enrolled in these studies. So the limitations are, there was no standardized categorization of intervention and outcome. So we used Tidier to describe it. We made the groups before we did any of the analysis, but we had to make that category because there was no standardized one. We're only able to include studies in English, and there were no UK studies. So for the UK context, we have nothing to report. The strengths are that we used a broad literature search, so we used grey literature as well as the databases. We didn't just include randomized controlled trials, so we did look at other types of studies. And for the hand therapy community, it's really important that this is upper limb specific. We're not pulling factors from low back pain or Achilles tendinopathy. So the next steps are to develop a core outcome set for work-related outcomes, and this is underway. And then together we need to think about standardized reporting for MSK work interventions. And that's something I would like to discuss with you all. So thank you very much for listening. That's part 1. I should say I only have 5 minutes for these. There's loads more info. Okay. Part 2. So also funded by the CSP Charitable Trust postdoc research grant, which is great, keep it in. We also surveyed UK hand therapists to see what their views were on providing work participation support for their patients. Same team, still no conflicts of interest. So our review questions, our study questions were, what are the reported provisions of work participation support for adults with hand and upper limb conditions by the UK hand therapy community, using the same definition of work participation as we had before? So that's return to work, remaining in work, increasing duties, hours, and work productivity. And then the second aim was to think about what are the potential training needs in this area, which sort of relates back to what Paul was talking about in the earlier talk. So we used an Australian survey that had already been published by Lisa O'Brien and team, and we refined that for the UK context with feedback from the British Association of Hand Therapy Clinical Evidence Committee. And then we disseminated this through our annual conference, which was last year, and electronically via e-bulletins. And we used descriptive statistics to analyse the findings. So we had 123 participants, which is 17% of our population, which is a massively good turnout. Normally we get between sort of 2 to 5% on a good day. So there is interest in this area. Of the respondents, the majority were experienced hand therapists. Most worked in the NHS, and 80% of their caseload was adults. Remembering we work in a mixed peds adults populations. Most came from from England within the UK, but these proportions are representative of the membership of the British Association of Hand Therapists. So one of the questions asked, which work participation interventions do you routinely use with your patients? And these were the top 4. So we had discussing graded return to work. Then we had signposting to a doctor, signposting to occupational health, and discussing psychological support. So for me, it was really interesting that the second and third of these were passing on the decision to talk about work to somebody else, because couldn't quite fit it in a hand therapy environment. So we also used a numerical rating scale to look at the top shows confidence in issuing the AHP Health and Work Report in pink, and issuing the fit notes in green. And you can see here that the majority of respondents were circling 0, so not at all confident in issuing these documents, despite there already being a year and a half at this point of us being allowed to issue fit notes, and the AHP Health and Work Report's been around for like a decade. I also asked about satisfaction. So that's satisfaction in blue with your involvement in work participation support for your patients, and in purple for the quality of work participation support you're able to provide. And this had a more normal distribution, but you can see that nobody is completely satisfied with that. So again, we asked about those 2 documents that we have to support our patients with work. Only 36% reported issuing a AHP Health and Work Report, and 25% reported issuing fit notes. Within their organisations, only 13% were issuing fit notes electronically within the organisation. I also asked about permissions for issuing fit notes. So we know that the legislation changed back in 2022. So 14% of people were able to issue them after completing the e-learning for health module. 9% completed the e-learning for health module, and then they had a local procedure that they also had to complete. And 49% were not permitted to issue fit notes at all in their organisation. So this is secondary care, but that's a big barrier there. And as Paul discussed in the last slide, training was a big need. 68% were looking for more training in work and health. So the barriers, very similar to what we all just put up on the Mentimeter: lack of time, lack of skills, concerns about managing patients' expectations with work and not really knowing what to say, concerns about legal implications of giving work advice, concerns about providing conflicting advice with the surgeons mainly, because a lot of these are post-operative patients. So in conclusion, the British hand therapy community are providing largely informal work support, and lots of signposting to other services rather than necessarily discussing in our practice. There was limited use of fit notes despite the change, and there were issues with permission. So that's something I'm looking at with the British Association of Hand Therapy to try and rectify that. And there's also a desire for work and health training, which is something hopefully to link in with Cameron and the ACPO team and see how we can use those existing resources. So the limitations, need to think about response bias. Probably people who are most interested were more likely to reply. Also, this is self-report, so it doesn't necessarily equal practice. And it was anonymous to encourage people to take part, but that means I can't look at clusters of distribution within similar hospitals or local regions. But this is the first time that work-related data has been reported for the UK hand therapy community. First time we have information on fit note use in our community. And so that's a benchmarking starting point, as it were. So the next steps, as I said, looking at fit note adoption, particularly how we can use routinely collected data to support this. We've got international collaboration. So this started in Australia. I've picked it up here. Now my colleagues in America and Canada are also taking this on board. We have an international hand therapy society, so we're working to deliver some work participation support advice globally. And then not forgetting patient impact. So we have patient partners involved and we're continuing to discuss this with them. So this one is published open access in hand therapy. So if you're interested in looking at it, you can get it through the QR code or just Google. Thanks very much for listening.
Thank you very much for that, Lisa. Has anyone got any questions? Yes, gentleman here.
Good man, he has all the questions, this one.
So thank you very much for that. It was really interesting and I think eye-opening to me. I just wonder if you touched on the fact that there weren't studies yet conducted in the UK, and I wonder if you're aware of any ones that are in progress or if there are any movements in that direction.
So there have been UK studies, but not specifically for upper limb. So Yellis Pryor and her team have done a lot of work on vocational rehab and work participation support in rheumatoid arthritis, which was the closest, but that was a systemic. So that that wasn't eligible for the study. And then Nadine Foster and the team at Keele have done quite a lot in primary care. But again, that was primary care MSK, so whole body. So it didn't meet our inclusion criteria. So there are studies, but more general MSK. But I would argue that upper limb is sort of a special case for work. You know, we need our arms in a slightly different way than if we have back pain, say, or an issue with our legs. So yeah, we're looking at it. It's coming. Thank you.
We've got some question from online.
The data you showed on confidence to complete the fit note was lower than the results underneath of people's satisfaction.
Yeah.
So do you kind of interpret that to be there's a barrier to people wanting to complete fit notes or seeing it as our role?
Yeah, so there was other data. I only had 5 minutes to present, but I think it's that people weren't, the documenting and having this formal statement of something that you've issued to the patient to take to their employer was a barrier, and there were lots of concerns around that, and the feeling that you needed to be 100% correct, and what happened if you said something wrong, and then what happened if something happened to them at work. And that sort of sat down one side, and then there's the talking and discussing work with patients, which I think most people will mention it and discuss it in passing necessarily, or they take their occupation at the beginning. And then do you have any issues type question, which is different. I think the fear is around this name stamping yourself on a formal document and getting it wrong, if I'm honest. Yeah.
There's some other questions from online.
Yeah. Well, this is one. So to follow up on that then, so that lack of it's the confidence, isn't it? You said stamping your name on something. What do you see as the next step in us breaking down that barrier?
Yeah, so I think we need to have there is training. So one of the other questions was, have you accessed the training? So it's free and it's available, but people haven't had time. They haven't been able to, you know, this is part of our practice. Why is it not one of our mandatory trainings that we have to have signed off? Why is it voluntary? Why is work not part of our everyday discussion in an MSK community? So it's that changing the culture, but it's also having access to training. It's having time to have access for training, mentorship in that area. And so I think I'm not an occupational health clinician, but I'm really interested in work and health. And I think there's almost a divide there as well. So it's like the occupational health team and the MSK teams. And I think we just need to be more integrated and share resources, because these things exist. It's just, you know, hand therapist in my team might not even know.
Would it be right in saying that these are more specialist hand therapists? So I find that quite surprising then, that if they've specialised, that they don't feel like the confidence and training, considering they're a niche clinician. Do you not find that surprising?
Not really. It's no different to the MSK world, I don't think. So in hand therapy, we do an accreditation. We do postgraduate qualification to become a hand therapist, but none of that includes work. It's all about not rupturing tendons after they've been repaired and what splints to make and diagnostic. And so, you know, a lot of these are advanced practice hand therapists and consultant hand therapists, and it's just not traditionally been part of training, and that's what needs to change. Yeah.
Any further questions? Yeah.
Was this just physiotherapists or was it occupational
No,
therapists?
it's mixed, and I didn't show it because I didn't have time, but the hand therapy as a community is 60% OT, 40% physios, and that was basically the proportions of the survey.
Yeah.
Is Terrific. Well, we've got one further question.
Guys, you give me a hard time.
This is great because people ask interesting questions. So with that, if you had physios and OTs, did you split the data up and see if there was a difference
Yeah.
between those two?
There wasn't. So I did, but there wasn't. So, and it also, we had, are you a 8A or above equivalent? Are you a band 6 or whatever? So there was no real difference we only had small numbers in those groups, and I didn't report it in the paper, but there wasn't anything to report really. There was no difference. Yeah. In the list of what work participation things do you normally provide, the least frequently reported but still encountered were things like interacting with the employer, supporting the patient. So there's a group of people, but only maybe about 5% of this sample who are super involved in work and health, but then there was just everybody else. Yeah.
Terrific. Well, on that note, I'd like to bring this morning's session to a close and thank all our speakers again for some really interesting and informative sessions. And hopefully everybody's got something that they can take back into clinical practice next week. So if you just join me in thanking our speakers. So sessions resume at 11 o'clock. I'd like to encourage you all to visit both the exhibitors who obviously have supported us in creating this conference for you, but also please do visit the posters. There's a number of individuals who have spent a lot of time, a lot of effort in producing their research, and I'm sure that they'd all like to talk about that with as many people as possible. So thank you again, and look forward to seeing you back at 11 o'clock.